a consequence of overextension or underextension of your GP. Okay, so while we will always do coronal restoration, so this is not something that we skip, no, uh, and so this is not a relevant item here. But yeah, so it's not related to this anyway. So letter C, irritation of periapical tissues due to leakage or extrusion. So if your obturation is short, no, the microbes, no, are able to get in and out more easily, and also because you also have more likely than not, retained infected tissues, no? So that's obviously an issue. Now if you have that's the usual problem there. If you have extrusion of GP, now GP or yeah, your GP is very likely to initiate an inflammatory response, no? So again, this will be an irritation, no, to the periapical tissues. Okay. Yeah. Number 33. Which of the following best explains why overfilled root canals are associated with an unfavorable prognosis? Reason why overfilled root canals are associated with unfavorable prognosis. A. Guttepercha enhances periapical blood supply, leading to overgrowth of tissue. While overgrowth of tissue is a negative thing, enhancing blood supply, no, enhancing periapical blood supply, it technically is a good thing, no. So yeah, and well, we don't. It's not a consequence of extrusion. Letter B, the presence of excess sealer and gutta-percha may provoke a foreign body response and inflammation, which I already mentioned earlier. But again, we have to continue reading just in case you have better answers. Letter C, overfilling strengthens the apical seal but delays crown placement. So it has overfilling does not have a positive effect to the apical seal. Okay, so it will not strengthen the apical seal. Letter D, overfilling improves long-term healing through increased adaptation of filling material. Again, overfilling is not no something that will improve long-term healing. Now, if you have been searching and looking at cases over the internet, you will see a lot of uh, cases that are presented wherein the you will see extrusion, no, and what they call the cauliflower effect and the apical deltas, no, um, of the canals, no. But these are all sealers, okay? They are not GP, okay? No, and so GP, if extruded, no, is not something desirable, no. Now, in terms of sealers, the reason why they're doing this is to show off that they've filled even the apical deltas. Okay, no, and because they're as so far, no, or if you're using sealer, no, that's made of MTA or bioceramics, especially bioceramics, no, they are considered biocompatible, and it's acceptable that they have been extruded past the canal. No, in terms of biocompatibility, no, they will not. They are known to not initiate inflammatory response. Now, this is in recent history. Now, whether something negative happens 10 years, 20 years from now, no, that's a different story. But the you might see this current trend and you might be confused why you're seeing a lot of this cauliflower effect going on, no, on the internet, on these cases that are being presented. But ultimately, experts will tell you that this is just vanity, no, vanity. They just want to show off that they're filling the apical delta with the with the sealer, no, but actually, no, we don't know long-term effect, no. If they've extruded, what will now be the impact of these materials, no. I just know that so far so good, they're biocompatible, but it's not really necessary and it's not recommended. Okay, no. You might be tempted to follow suit, but it's not something that's acceptable in the practice just yet. It's just for effect, for for visual effect and bragging rights, no? But it does not enhance the treatment. Right? Yeah. Let's see. Okay. Number 34. Now, which of the following clinical situations contraindicates a single visit endodontic treatment? Okay. Um, okay. This one is a bit uh, controversial. Now, take note, no? As much as possible, in the recommendation, no, is for us to perform RCT as quickly as we can and complete it as quickly as we can. Okay, but for beginners, no, definitely it's not possible. Now, for those who are more seasoned, no, in terms of doing endodontics, uh, they would still try to hold off, no, uh, doing single day endo, no, if it's possible. No, it's just that the reason for doing endo quickly is you want to seal and yeah, you want to seal the entire thing as soon as possible and prevent destruction. Okay, but if you think that there's need to observe, no, the case, or there's need to wait for healing or repair, no, then by all means, no, you don't need to do a single visit endo. No, of course, some patients would prefer single visit endo because they don't want to have to keep going back to the dental clinic. But you have to use your clinical judgment. Okay. Now, as for the textbook recommendations, then yeah, let's read through the choices here. No, letter A: necrotic pulp with asymptomatic apical periodontitis. Letter B: vital pulp with reversible pulpitis. No, um, letter C: pulp necrosis with condensing osteitis and no symptoms. No? Letter D: persistent exudation in the canal during preparation. Yeah. So, actually, 'di ba? Letter B, letter B is not indicated for endo at all, 'di ba? No? And letter C, letter D definitely, no, um is not something that you can obturate. No, because it's you still have a persistent exudation during preparation. So that means it's not dryable yet. You still have a abscess there that's coming out. No, so in this case, no, this question is defective. No, I cannot give you one answer for this question. No, at the very least, no, textbook wise, no, they would still, for example, letter A and C can undergo single visit endo, no, can, no, but I'm not saying it's recommended, but it can. Now letter B and D, now letter B, reversible pulpitis, so no, unless no, what you're the reason why you're the reason why I would choose letter D instead of letter B is, for example, you're doing endo on a vital pulp with reversible pulpitis for pre-prosthetic reasons. Okay, so the diagnosis of the pulp, no, is reversible pulpitis, but that's not the reason why you're doing endo. Okay, so you're doing endo on this case anyway, and yes, you can do single visit endo, so it's not a contraindication, right? So in this case, the best answer would be letter D. Okay, that's what you have to. You really need to think in a more complicated manner to come up with an answer for number 34. Okay, do you understand this? Why my answer is letter D? Did you get it? Or do you disagree? Baka nag-disagree kayo, sige lang. I'm saying, no, uh, yeah, you may consider, no, that because no, this tooth, no, can be treated with with endo for a different reason. So it will not be a contraindication. Okay? Tama. Number 35. Number 35. Which of the following is a valid reason for opting for multiple appointments rather than a single visit endodontic treatment? So, basically, no, what you're saying, what you're asking here is, when will you do multiple appointments? Okay, what will be a reason for you to do multiple appointments or not obturate immediately? Okay, letter A, presence of microbiota confirmed by culture testing. So, because of this choice, you know that this is a very old question. Okay, now because we now do not do culture testing. It's not even something that's recommended in the textbooks anymore. It's mentioned in the textbooks, but it's not something that's recommended. Okay. It is said that culture testing is not done anymore because the species that are cultured anyway are not species that you will find in deceased pulp. Okay, during culture testing. So, and then there are a lot of other errors associated with cultural testing. Okay? Yeah. Anyway, letter B, complex or difficult to treat cases requiring careful management. So if you know that the case is already difficult to manage or a bit complex, then you have to inform your patient that this is not doable in one appointment. Okay? Letter C, availability of advanced obturation materials. Of course, if you have this, then it can make your work easier. Letter D, improved access to canal anatomy and anterior teeth. Again, this is not something that will cause you to recommend multiple appointments. So the best answer here is letter B. Okay? Yeah. Number 36. Which of the following is not a desirable property of core obturating material? Now, when you say core obturating material, this is what your GP, no? As opposed to the sealer. Okay. Now, of course, there are other materials that can be used as obturating material, but this is we're talking about desirable properties. Okay. Letter A should be radio opaque. Of course, we want it radio opaque. So this does not answer the question because we're looking for something that's not a desirable property. So meaning all of the choices here are desirable properties except for one. Okay, so we're looking for them. We're looking for it. Letter B should shrink slightly to adapt to canal walls. Is shrinking slightly a good thing or a bad thing? Adapting to canal walls is a good thing, but shrinking slightly, is it a good thing or a bad thing? Dimensional instability. Letter C should be easily removed from the canal if needed. What does this mean? What does this mean? If retreatment is necessary, you should be able to remove it easily. Then yeah, it is a good thing. Okay. Letter D should not stain tooth structure now, as much as possible. Because one of the issues of endodontic therapy, especially those that will undergo composite final restoration or pure porcelain or pure or zirconia or any other possibly translucent restorative material, is discoloration. Okay, so you want something that will not stain to structure. So this will be ideal, or desirable. Okay, so which of these listed down is not a desirable property then? What's your answer? Number 36? What's your answer? Letter B. Okay, letter B. All right. Tama. Okay, letter B din. Tama. Okay. Ganun tayo, try to come up with the answer. Wag niyo lang antayin yung sabihin ko yung answer kasi it's not gonna help you develop your thinking process if you're just gonna wait for me to give you the answer. Okay? All right. Which of the following statements is true regarding solid obturation materials, particularly gutta percha? Okay. So of course, no, if you don't know the details about gutta percha, you might have a bit of difficulty. Okay. Yeah. Gutta percha is composed of 75% gutta percha and 20% zinc oxide. Because if you don't know, gutta percha is actually from a tree. No, this found in Malaysia. No, so yung actual na raw material of the gutta percha. But no, the bulk of gutta percha is actually what, not yung gutta percha itself, no, but zinc oxide. Okay, that's why you can use the same solvent for your sealer and gutta percha. No? Okay, the main advantage of semi-solid paste over solid obturating material is better length control. No? Actually, you have better length control with solid obturating materials. Okay. No? Letter C. Gutta percha was introduced less than 100 years ago as an obturating material. No. Gutta percha has been around for much longer than 100 years. Okay? Tagal na, no? And letter D. Solid obturation material allows better length control and seal. Okay. So, solid obturation material allows better length control. Yes, but not seal. Ah, ayun, no? Okay, so this is a bit tricky, no? Because if you don't know the details about gutta percha, then yeah, you might find this problematic. Okay. Okay. So, but the answer here is letter D because of the seal. That's the so it's not necessarily true. Of course, you also have other. You will have gutta percha that will have better fit in the canal, but yeah, but your sealer, no, is the one that's providing your seal. Okay? No? Wait lang ha. Yan, I think I need to share kasi yung ano. Wait lang, wait lang, wait lang. Yan. Ano ko lang to. Just show you the composition of the percha. Yan. Okay? So, this is the composition of your GP. Okay? So, the GP, actually, yung bulk niya is zinc oxide. Okay, your GP cones. Okay? And, disadvantages, disadvantage. This is the sterilization method. Advantages. Okay, disadvantages. Okay. Ayan. Okay. Let's go back to our ano. Hmm? Magkano? Magkadali. Or maybe I can just close this one para mawala. And then, stop sharing lang. Yan. Mm-hmm. Okay. Number 38. Okay. Okay, let's go for number 38. Can you see? There seems to be a bit of a delay. Can you see the questions? Yes?
Yes, ma'am.
Okay. Okay, number 38. Which of the following statements best describes the difference between standardized and conventional metapercha cones? Ano ba yung ano, standardized? Hmm. So let's see. A. Standardized cones have variable taper and size depending on manufacturer, while conventional follow ISO sizes. Letter B. Standardized cones match the taper and tip size of endodontic instruments, whereas conventional cones have different tip and body sizes like fine to medium. Letter C. Conventional cones being and are always used with rotary files. Letter D. Both standardized and conventional cones follow identical sizing systems but differ in color coding. This is a bit difficult to answer if you don't know what they mean by conventional and standardized. Okay, yan. So, mm-mm. So when you say standardized, this refers to uh, those with fixed, no, uh, tapers and fixed what do you call this, fixed taper and fixed diameter, no, and or tip size. Okay, yeah. So for example, if you say ISO standard, okay, so what's the standard ISO taper for your files, your cones, and your paper points? What's the standard taper? ISO standard. Ay, importante to, no? When you go out and buy, you attend ESP convention or PDA convention, and you go shopping. Okay, on your list you have GP cones, no? But you now have you now have a ito may discount, okay, but it says 0.06 taper. Is that okay? Or it says 0.02 taper. Is that what I'm looking for? Hmm. Oh, ano, 'di ba? And then the there are also what you can also say that you have the more modern cones, no, which will have specific sorry, which will have different sizes and tapers, no, from your ISO standard. Okay, no. So you need to make sure that if you're, for example, using a specific uh, rotary filing system, that your GP will match, no, the file system that you're using. So if especially if you're planning to use single cone technique, okay. So for example, pro taper, no, the final file that you will use, no, will be the same size as the cone, no, and same size in terms of diameter and same taper, no, and it because of this they're exactly the same, no, so that's why you can do your single cone technique. Okay. Again, no, because of the letter C has always, so you need to eliminate this. Okay. No, and standardized, of course, means they're standards or they're not. No, no, they're not variable. They have fixed. No. taper and size. Okay, and yeah, and your standard cones are your ISO. Well, ISO is among them. No? Okay. Wala makasagot kung ano yung taper ng ISO. ISO standard taper is 0.02 millimeters. 0.02 millimeters. No? So, you have an increase of taper of 0.02 mm per mm length of the file. Of course, it's not a sudden 0.02 increase. It's gradual. No? But at so from D0, no, so which is the tip, and then you go to D1, no, it has an increase of 0.02 mm. And you go to D2, no, another increase of 0.02 mm. So every D is your or depth, no, will be 1 mm. How long is the standard ISO file? I'm not talking about the handle and the shank. I'm talking about the working end. How long is the actual file, the working end of the file? You know, it's 16 mm. 16 mm ang standard ISO. So the ones that you're using, you look at them. No, even if the handle, even if the shank is long, no, from the hand, diba, you have the handle, the shank is long. But if you compare the working ends, they're all 16 mm. Yan yung ano, standard ISO. No? So kahit na 21 mm file, 25 mm file, the working end is still 16 mm. If it follows standard ISO, yun. And the taper is 0.02. Okay? Now, some of you I saw gumagamit ng 0.023. So may dagdag na onte. This is okay lang naman. Okay? No? But you have to know kasi know what you're using and what's appropriate. No? So for example, for lateral condensation technique, that you will use your standard ISO, no? GP. Okay? Here you cannot use single cone technique, no? When you use ISO filing system. Okay? Nagets nyo ba? Na, 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 naintindihan nyo yung sinasabi ko? Mamamaya, ano yun? So, so there are different filing systems kasi. Okay? Ayan. So, the answer for this one is actually letter B. Okay? And, kasi before, wala pang, syempre, before standardization, there was yung conventional, they just use the term, oh, fine, medium, yan. So, that was the conventional. A long time ago. And then they came up with the standardized, yun na yung ISO. And then after that, they came up naman with the more modern cones that now have greater taper and match specific filing systems. Okay? So yun, meron pa kasi ibang generation, hindi lang conventional and standardized. Okay? Alright. Now let's look at number 39. 39. Which of the following statements accurately describes the various methods of gutta-percha placement during root canal obturation? Yan. Letter A. Medyo mahirap to, no? Which of the following describes various? Okay. Letter A. Lateral compaction is performed by applying long vertical force using heated carrier. We know that lateral compaction technique doesn't use a carrier. No. So the carrier-based system is what? Is the one that uh, is softened by heat nga. No? So with lateral condensation, lateral compaction technique, we also do not apply vertical forces. We apply lateral forces, right? Okay. Letter B, vertical compaction technique requires lateral force to compact the cone against the canal walls using a spreader. So this is the total opposite. No, this is now your lateral compaction technique. So this description on letter B is actually referring to the lateral compaction technique. So baliktad, right? Okay. So letter C, one technique involves chemically softening the gutta percha with solvents to enhance adaptability. Okay, so we have our gutta percha solvents, no, and yeah, this is actually no describe one technique. It is not something that's recommended, but it is at least accurate. Okay, kasi nga letter A, letter B, they're both wrong. No, they're opposite direction. Okay, letter D, the carrier based system uses an unheated metal rod to deliver gutta percha directly into the canal. So yes, it's wrong because the carrier based system uses heated carrier nga. Okay, so out of the statements A, B, C, and D, only letter C, while it's not their most recommended, no, or favorite or ideal obturation technique, this is the only one that's described correctly. A, B, and D, no, are incorrectly described. Okay? No, so you can check this out in your books if you want. But yeah, essentially, yun lang. And explain ko naman na. Lateral compaction is the one that requires lateral force to compact the cone against the canal walls using a spreader. And vertical compaction technique, well, it depends on what vertical compaction technique you're using, but it uses a plugger. Okay, that and you apply forces vertically. Okay, now your your carrier based system would use a heated carrier, no, a metal rod to deliver the GP, no, into the canal, and then it will soften, no, the GP, and then you withdraw the carrier. Okay. Yeah. Let sorry. Kaya you need to give yourselves enough time to read the choices. No? Because if you don't read them very carefully, then you might miss something. Okay? It might sound familiar to you, and something might not sound familiar, like this one, di ba? In letter C, it's not something that you're familiar with, but this is the right answer. Okay? No? In this case, the one that's using solvent. Okay. No? Next, number 40. Which of the following statements is true regarding resin-based obturation materials as a potential replacement for gutta percha? Okay. Letter A, the resin core material is primarily made of gutta percha and zinc oxide. Siyempre, mali na yan. Resin systems aim to create a monoblock using polycaprolactone and dual-cured bis-GMA resin sealer. Letter C, the self-etching primer in the resin system is known to be highly cytotoxic and mutagenic. Siyempre, no, this is no, not something that was designed into this. No, so it's not highly cytotoxic. It's not um, descriptive, no, of this method. Resin obturation materials are contraindicated due to poor biocompatibility and high mutagenicity. Uh, Again, this is not uh, something that they were aiming for. So the answer will be letter B. SMB systems aim to create monoblock using polycaprolactone and dual cured bis-GMA resin sealer. So dual cured here is the main uh, I would say one of the main important factors, no? Because it can cure by itself inside, or you can promote or initiate its curing or polymerization. Okay, number 41. Which of the following statements about silver points as obturating materials is true? Silver points were, the thing a long, long, long time ago. Hindi ko na to inabutan, no? But yeah, uh, that this is one of the pioneering obturation materials. Anyway, letter A. Silver points are preferred because of their excellent long-term sealability and adaptability. Letter B. Silver points are made of stainless steel and correspond to arbitrary file sizes. Of course not. Letter C, silver points are composed of pure silver and match the size of the last used file during instrumentation. Letter D, silver points are easily removed and widely recommended for modern endodontic treatment. Okay, so we're looking at statements that are true about silver point obturating material. Okay, so letter A, obviously it's not sealable. No? Letter B, and not adaptable against the walls. It's super solid. Letter B, silver points are made of stainless steel and correspond to arbitrary file sizes. Silver nga eh. Okay, so no. Letter C, silver points are composed of pure silver and match the size of last used file during instrumentation. And this is how they select the size. Okay, it's based on the last file size. Okay, and yeah, it's silver. Letter D, silver points are easily removed and widely recommended for modern endodontic treatment. So we know, number one, it's not our obturation material of choice. No, and silver points, of course, are solid. So they're more difficult to remove compared to GP. Okay? No? So this is not it's more difficult for retreatment. Okay, because of that. Okay? 42. Which of the following is not a desirable property of endodontic sealer? Okay. So based on this question, now the choices should be full of desirable properties. So what we're looking for is the one that has a negative meaning or one that's not desirable. Okay? No? So letter A, insolubility to oral fluids. Definitely we want that. We want our sealer to be insoluble. Okay? Letter B, high shrinkage upon setting. Oh, this is not something we like. No, because this is dimensional instability. So dimensional instability, no, especially high shrinkage, would mean that there could be the possibility of leakage. So we don't like this one, right? Letter C, radio opacity. Of course, we want it to be radio opaque so we can see it on the radiograph, right? And letter D, bacteriostatic properties. Ideally, if the material can be bacteriostatic, then that's beautiful. It's a very good thing because it will prevent reinfection, right? Of course, these are desirable. We're not saying that all your sealers have this, but this is definitely desirable. So the one that we don't like, no, is what? Letter, this one. This one, minsan kailangan ko lang magtanong para matest kung nakikinig ko ba kayo. Oh, which one is not a desirable property out of A, B, C, and D? B. Okay. Yan. Kahit obvious na kasi sinabi ko na eh. Binigay ko na lahat ng clue eh. Okay, thank you. Gusto ko lang ma-verify that you're still listening. Mamaya wala na pala akong kausap. No? There are 40 of you but nobody's listening. Nako. What a waste of my energy. Okay. I'm just saying, I don't want to waste my energy and my time. Uh, uh, today is today is family day, right? For every one of us. So even if most of my family members aren't around, this is the only day of the week that I spend with my dad. Now, my dad is not my favorite person. I have to be clear. But in the mornings, and then we spend the day, outside. We'll eat and whatever, go window shopping or shopping. So that's usually how I spend my Sundays. So if I'm spending my Sundays working, then that's reduction of my family day, right? So I hope that uh, I know that for you guys, you've been using your weekends also for review, but then this is with a specific goal, right? You have your city schedules, because it's um, it's required, not only because it's required, but it's for your uh, graduation and for your passing the licensure exams. Okay, no, so me, I don't have to pass the licensure exam. But I'm doing this because one, it's not supposed to be this is not my original schedule, but yeah, they requested Thursday ba yun? No, Thursday. I was asked to fill in today, no? Last Thursday lang, Doc, is it okay? Kasi ganyan nagulo yung schedule. I was like, and then, okay, anyway, sige, fine. Okay. All right, moving on. Number 43. Which of the following is a disadvantage of zinc oxide eugenol based root canal sealer? Ayan. So we in school, no, and still in many situations, in many cases, in many clinics, now zinc oxide eugenol is still used as the root canal sealer. Okay, but I did mention earlier MTA, bioceramics, no, so these are already the preferred root canal sealers by endodontists, especially, especially bioceramics. Now, letter A, lack of historical success in endodontics. So obviously, this is not an issue with ZOE because ZOE has shown, a lot of historical success. Letter B, strong adhesion to dentine. Well, it's very adhesive. Actually, as a matter of fact, it's so adhesive, it's annoying, di ba? So difficult to clean, no? Letter C, staining of the tooth structure. Possible. As I said, it's one of the issues, right, of RCT. And letter D, rapid setting within minutes. No, no. Zinc oxide eugenol is known to be slow setting. No, the one that we use for endodontic sealer is definitely designed to be slow setting. So, no, while staining, no, on the tooth surface can be prevented, no, this is, no, the most acceptable reason, or answer for this question. Letter C. Okay? No? So staining can be prevented by cleaning the chamber properly, no? So and before you do your final restoration. Okay? Anyway, no, and of course there are other sources of staining as well, no? So yeah, but again, they can be prevented. Number 44. Which of the following statements about the new flowable gutta-percha obturation system is true? Yeah. Letter A. It requires external heating to flow into canal irregularities. No, so, but earlier you already encountered yung carrier concept. Yun yun eh. Letter B. It is composed of coarse gutta-percha chips and epoxy resin only. Of course not. No, you have mul- uh, multiple components there. Letter C. It self cures in approximately 30 minutes, expands slightly on setting, and needs no compaction. Okay. Letter D, it cannot be removed with conventional retreatment techniques. This is no. As long as there's GP there, then you can use conventional retreatment techniques to remove it. That's the advantage of GP kasi. No? That's why even in reality, no, actually, no, if you want to seal the canal, no, you can use MTA, you can use bioceramics to seal the canal. Diba? No? Kasi, even if you extrude, they're biocompatible. Fine. They provide good seal. But the problem is, what about if you need to re-instrument? What if you need to do retreatment of endo? Then you're now in trouble because they're difficult to remove. So that's why they will still put GP there. That's why the most common technique now is your single cone technique. No, for these for the at least for the endodontists who will use, these rotary file systems, rotary file machine driven systems. Okay, no, so yeah. Uh, okay, so what's the answer here? Letter C. Okay, letter C. All right. Number 45. Which of the following is not a standard evaluative criterion for assessing the quality of obturation on the radiograph? So, based on this question, so let's adjust our brains to understand this question. This question means that all of the choices here are standard evaluative criteria for assessing the quality of obturation on the radiograph, except for one, and that's what we're looking for. Okay? No? So that's how your thought process should go, no, when you're reading these questions. Okay? Again, which of the following is not a standardized evaluative criterion for assessing the quality of obturation on a radiograph? Okay, let's see. Letter A, presence or absence of radiolucent voids within the obturation material. Letter B, the density and sharpness of obturation borders. We want to see this. We want to check this because sometimes, no, our eyes might trick us. No, and if you look at a different angle, no, it's actually not obturated properly. no, and the denseness and sharpness will be clues, no, on whether you want to take a different angle of this radiograph. Okay. Letter C, shape of the access cavity preparation. Uh, Letter D, the length and taper of obturation material relative to the canal. Of course, you want to fill the entire canal. You want to fill the shape. You want to have the correct taper and length. No, so this is definitely something that you want to see. So, what is not a standard evaluative criterion is the shape. Okay, there's no specific shape, no, especially your access cavity preparation. Okay, the shape of the access cavity preparation is not seen on the radiograph for obturation. Okay, however, no, let me just clarify. No, let me just clarify. If you're checking for the quality of your obturation and you see voids, okay, you definitely want to check, no, what is the cause of the voids. No, sometimes it's what, it's because the access you made was too small, but you don't see it on the radiograph. No, the access itself. What you see is there's a void, no, and the tapering is what? No, the tapering is a clue. No, now there's a sudden change in the in the taper. Okay, so that's why I'm telling you, uh, you do not see the access cavity preparation, but the shape of the canal itself, the shape of the obturation itself, you can see, and it serves as a clue. Sometimes it's not the access, but sometimes it's the shoulder. No, so if there's a lingual shoulder, for example, that you did not shape properly, then you will see this as a clue of a reason why no your obturation was not done properly. Okay, yeah. Number 46. I think it's a it's a bit challenging for you to um picture these cases of endo in a way kasi for some of you you only did very few endo cases, no, some of you kasi your compre had a lot of endo, no, some of you, but some of you, for some of you, you only did very few, like ano lang, two lang, no, because it's only required, you're only required to do one mono in clinic 2 and one multi in clinic 3. That's the minimum. And if you did multi pa on premolar, no, and then so some of the concepts that you will uh, see, no, will probably not mean so much, no, for you. No? That's because that's one of the things that I also discuss, no, with clinicians who discuss their cases with me, no, and even during the management, I explain why uh, this is so and so. Why is this challenging? What do you need to do because we're seeing something that's a potential problem? No, like last week I saw there was last week there was one who was doing multi endo, the MB canal of the mandibular molar was a bit difficult to engage and get into. So I gave instructions on how to navigate. So he spent the entire session on Saturday just navigating that one canal, but yeah, he was able to get to the working length of that canal. That was a bit challenging, but I think one of the things that make reviewing for endo difficult for you is because a lot of this is just memorization and difficult to imagine for you if you haven't done enough endo. Okay, no, of course there's still some memorization involved in there, but it's easier to understand when you've done more and you've assessed and evaluated what was going on when you were doing your treatment. Anyway, number 47. Why is it essential to evaluate restorability before initiating root canal treatment? Okay. So usually, when I approve endo cases, that's one of the first questions that I will ask. What will be the final restoration? Because Now, this is a very important component of case selection, because if you cannot place a final restoration, then what's the point, right? What's the point of doing endo? Okay, as it is, now when you do endo treatment, there's already the risk of what, destroying more sound dentine structure, no, than you initially planned. Okay. In the first place, what you see on the radiograph is not exactly how it is in real life. Two, no, in the course of your treatment, errors can happen. No, just looking for the canals, the orifices, no, might cause you to gouge, diba? No, so what more? No, if at the very beginning, from the very beginning, you already see that okay, this is, this is problematic. I'm probably not going to be able to place a final restoration. Then, no, this will tell you, no, whether to start endo or not. So even before the suggestion of doing RCT comes out of your mouth, no, and you suggest it to the patient, you should already be thinking not just of the diagnosis, but also the restorability. Okay, this will also help you decide whether, okay, maybe right now it's not restorable, but can I do something to make it restorable? Okay, so will crown lengthening suffice? Will this work? Will what crown lengthening technique will be my choice for this one? Will it be surgical? Will it be orthodontic extrusion? Okay, so yeah, all right. So what will be, no? Why is it essential to do this? Letter A, to avoid the need for anesthesia during obturation. Of course not. No. One, do you need anesthesia for obturation? No. Okay. And also, what does anesthesia have to do with the restorability? Anyway, letter B. Because restorative failure is more common reason for tooth loss than actually endodontic failure. Okay, pwede, no? Letter C. So that the pulp vitality can be maintained. May, of course not. No, because we're talking about here final restoration for endo. No? Letter D, to ensure the apex can be easily located during instrumentation. And well, as much as we want the apex to be easily located during instrumentation, that is not a reason for evaluating restorability. Okay? So, the answer for this is letter B. Okay? Next. Number Number 48. Which of the following is not one of the main objectives in selecting a final restorative material for an endodontically treated tooth? Okay. So speaking of final restoration of an endodontically treated tooth. Okay. And letter A. Again, reading the question, which of the following is not one of the main objectives? So, meaning, based on this question, the, the choices here are objectives of selecting final restorative material or restoration for an endo-treated tooth, except for one, and that's what we're looking for. Okay? So letter A, to replace the missing part of the tooth structure. B, to protect the remaining tooth structure from pathology. Okay, so ano if kasi a lot of you have undergone this the build up with the molar band or SSC that's cut off, etc., etc. Okay, fine. I've never used that. I've never seen it used by endodontists that I've encountered before. I've never seen it used in ESP uh, and studies. No, so I don't know exactly. Uh, but okay, fine. As long as it's not harmful. Okay, I will accept it as long as it's not harmful. But last last week, I saw a case that I had to have the SSC uh, support, no, kasi wala namang, obviously walang molar band, so they use SSC that's cut off from the cusp tip to support, no, the build up. I had the clinician remove it. No, one, that was not part of our treatment plan. Two, it was unnecessary. Three, and the most important reason was because it's gonna be harmful for the tooth in the long run. Why? because I saw, no, that it had a huge, more than 1 mm overhang. No, that's at the gingival level, actually slightly subgingival level. No, so I had it removed because he might be doing RCT on the tooth only to end up extracting it. Why? The potential for periodontal problem and recurrent caries was really huge. Okay, so yeah, please don't just, monkey see monkey do. Okay, don't just do something because you saw somebody else do it. You need to use your you have to be more discerning. You have to um think of the long term, no. So that includes your decisions for your final restoration. Okay, no. So yeah, so you want to protect the remaining tooth structure from pathology. So what you're doing is actually, endangering the remaining tooth structure. Then I'm sorry, but it's something that I will really disagree with. Okay, no, I strongly disagree with, or definitely remove. Okay. Letter C, to restore function, aesthetics, and provide stability. Of course, aesthetics would be more of an anterior tooth issue. No, function for everything and stability for everything, of course. D, to reduce the cost of restorative procedures. So while yes, we want, especially our patients, our patients would want to reduce cost, but it's the least of our priorities. Okay, it's the least of our priorities when it comes to choosing the final restorative material for our endodontically treated tooth. So the best answer for this question is letter D. Okay, yan. So nila nga, follow up ko lang yung sinabi ko kanina. Okay, the use, again, the use of molar bud, SSC, blah, 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 it's not something, no, that's a practice, no. In and it's not something, and it's also not something now, wow, cowboy, unconventional, thinking out of the box. No, no, you, especially nowadays when the adhesive techniques, no, adhesive materials in dentistry are very good. Composite is also very good. No, if your restoration is falling off, no, then you have to be concerned about your final restoration. Okay, no, so if you're not able to place build up there, no, or your build up keeps falling off or keeps fracturing, then you already should be concerned about your final restoration, or what final restoration you're going to put there and whether that's going to be successful. Okay, because the temporary restoration, this is a general rule for temporary restoration. Okay, it should copy your final restoration in terms of form and function, no, everything else except longevity. Okay, so the contacts, no, whether it's the proximal contacts, the occlusal contacts, the function, aesthetics, no. So ayan, makakarinig na naman ako, pangitan nyo yung build, yung temporary para bumalik ang patient. In all honesty, if you were the patient, tapos pangit yung ginawa sa inyong temporary, what will you think? You'll be scared, no, that the dentist, no, probably doesn't have a good eye. Diba? Dentist might probably not give you a good restoration. Kahit na ano pang sabihin ng dentist na di bali, temporary lang naman yan. No? You'll be scared. No? Your temporary restoration should already be a practice for the final restoration. Okay? Now you're testing for so many things, yung contacts, yung bite, yung function. You'll be able to detect if the patient has a parafunctional habit, for example, no, no, and what to watch out for, no, and even the bite, which you might not have seen originally, the problems with the bite. Okay, no, so please, no, this is this is something critical, and definitely do not cause more problems. Okay, so if your temporary restoration, including if you want to use yung molar band nga or whatever material you're using there for your temporary restoration, it should have a good relationship with the margin of the tooth. Okay, there should be no overhang There should be no impingement of the gingiva. You should respect, no, the periodontium. No, and you should prevent, no, recurrence of caries. No, if you cannot do that, then your temporary restoration is already wrong. Okay? No? Nanggigigil ako dito kasi I could already see the problem eh. No? So after so many sessions of doing endo, sira. Wala. Okay? No? It might not be apparent immediately, but after some time, wala. Failure yan. Okay? No? It's either a caries issue or a periodontal issue. Okay? So, anyway. Ganun din yung mga perio cases niyo. You have to a lot of cases kasi hinahanap mobility, recession. That's not your basis for diagnosis of periodontitis. Kasi pag ganun na, it's already uh, more difficult to manage. Kaya noon si Doc Tony inis na inis sa mga prosto rehab ng perio dahil dyan eh. Kasi hinahanap yung malala na. In actuality, we have to learn how to detect periodontitis early, no, to serve our patients. Okay? Ayan. Anyway, let's go to number 49. Which of the following is not a common change that may occur after a tooth has undergone endodontic treatment? Okay. Which of the following is not a common change? So, meaning, all of the choices here are common changes that may occur after the tooth has undergone endodontic treatment. Okay? Except for one, and that's what we're looking for. Okay? Letter A, loss of tooth structure due to caries or treatment procedures. Well, yeah, obviously that is a change. Letter B, increased dentine moisture due to loss of vitality. No. Letter C, alteration in physical characteristics such as reduced dentine moisture. Well, these two are actually what? Uh, B and C are actually a bit opposite of each other, right? Letter D, altered tooth appearance from structural damage or procedures. By the way, no, altered appearance, of course, is also a common change. Now, I'm just gonna point this out. No, so one of the other tricks or tips, no, for choosing the right answer. If you see two statements or two choices that are the opposite of each other, especially those that are really parallel, no, except for just one part, then in all likelihood, one of them is the correct answer. Okay, so you have what, four or five choices, but you see two statements that are exactly the same except for one part which makes them opposite of each other. Then one of them is the correct answer. So again, that's another trick, for or tip for taking multiple choice exams. Okay, ayan. So, will dentine lose moisture due to loss of vitality? Yes or no? Yes. No. Yes. Okay. No? Will it have a big impact? Not really. No? Kasi mga 9% lang siya ng loss of moisture. Okay? So, according to recent studies, kasi this is a very, very long, yeah, long believed concept, no, that the fragility of endodontically treated teeth is because of the loss of moisture. No, but yeah, it has loss of moisture about 9% according to studies. Okay, but no, the primary cause for fragility, no, is not this loss of moisture, but it's more of the chemical changes that occur because of irrigation and medication of our endodontically treated tooth. So sodium hypochlorite, our chelators, no, are actually the main reasons for the increased fragility. No? Of course, there are others, no, but yeah, hindi pala yung loss of moisture actually. Okay, but it's of course it still has a bit of contribution, but it's not that big of a significance. 9%. Okay? Yan, mas ano lang, medyo updated, ano lang, information. Okay? Alright. Number 50. Kaya pag nakita niyo akong nanggigil about something, it's because I've been seeing it a lot and it's already uh, causing problems, no? Minsan nagkakaroon ako ng ethical crisis. No, because of course I don't want to cause harm, no, to patients, but at the same time I don't want to disagree with my fellow CIs, no, and undo what has been done or what they have approved, no. Kaya lang, no, sometimes talaga I'm forced to do it, no, kasi it's a matter of bigger consequence or impact. Okay. Anyway, number 50. When is it generally appropriate to place a permanent restoration after root canal obturation? Okay. At ano yung this is a bit tricky, no? Kasi there will be multiple studies saying different things, no? But we do want to place the final restoration, no, sooner, no? Just like we want to obturate also as soon as we can, okay? But we do want to observe at least, no, the impact of our RCT, okay? So do we do it immediately after obturation, regardless of symptoms? No, now the regardless of symptoms is the one that made this false. Okay, no, so it's not letter A. Letter B. After at least 1 week, ensuring that there are no flare-ups. Maybe, sure. Letter C. Only after the patient experiences significant post-op discomfort. Of course not. We don't want this. Okay, so your only two options, no, actually will be letter B and letter D based on how these choices were formulated. No? Kasi nga, letter A is wrong because of the part regardless of symptoms. Letter C is wrong because we do not definitely, post-op discomfort is something we don't want. Okay, now letter B kind of makes sense. Letter D, no, also makes sense. Okay, no, because as much as possible, we do want to seal this off, no, and protect the tooth and the canal, no, that we've obturated ASAP. Okay, no, but if you look at the more recent references, the answer would be letter D. Okay, now of course it will depend on your final restoration. Okay, no, because if your final restoration is post and core, of course it's impossible. If your final restoration is PFM, again it's impossible. Okay, no, but if it's composite, no, actually that composite buildup that you did is already enough. Okay, no, so for example, if in letter A immediately after obturation, if it doesn't have regardless of symptoms, then letter A can actually be an acceptable answer if depending on your final restoration. Okay, because a composite restoration is an acceptable final restoration. Now this will depend on the remaining tooth structure. Okay, how large is your access and how large is the tooth structure that was lost and how large is the remaining tooth structure and what is the role of this tooth in the general picture. No, is it an abutment of an FPD? Is it an abutment of an RPD? Does your patient have parafunctional habits, etc., etc., etc.? Okay, so when you assess for the final restoration of an endodontically treated tooth, no, there are actually multiple factors that you're looking at, and you don't only have one option, you have multiple options. Okay, so let nobody tell you that a composite restoration is not an acceptable final restoration for an endodontically treated tooth. Okay, no, so it's false, right? You have to understand this, huh? Again, it's one of the things that I've been hearing. Okay, it all depends on multiple factors. Okay, so don't close your door, no, to other options. Okay, it's not, there's not one uh, perfect restoration. Okay, 51. Which of the following is not typically a factor to consider when choosing the type of final restoration for an endodontically treated tooth? Which of the following is not typically a factor to consider? So, meaning, now again, based on this question, all the choices are factors to consider when choosing the type of final restoration for your endo-treated tooth, except for one, and that's what we're looking for. Okay? Letter A, oral hygiene potential of the patient. Pwede. No? No, so of course, there are some patients who are really very poor with their oral hygiene, and you're now hard pressed to think of what can we do for this patient. Letter B, location and function of the tooth. So as I said earlier, no, the role of the tooth in the entire picture, no, is a consideration. Letter C, amount of remaining tooth structure. Letter D, patient's blood pressure. So, of course, letter D will be the least priority, no? So, not typically a factor. Letter D. Okay? Ayan. Number 52. Which of the following conditions is most appropriately managed with a full jacket crown in an anterior tooth? Which of the following conditions is most appropriately managed with a full jacket crown in an anterior tooth? Letter A, mild tooth discoloration. Letter B, peg-shaped lateral incisor. Pwede. Letter C, tooth with minimal crown destruction. Letter D, tooth with high caries index and malalignment. Okay. Now, if the tooth has high caries index and malalignment, maybe I'm not even going to put any restoration there. Just, you know, I'm not going to do endo on this tooth. Maybe I'll just, decide to extract it. Okay. Anyway, yeah. So because the peg-shaped lateral incisor is already uh, wrong in form anyway all around, but it doesn't have a huge amount of uh, tooth structure that's lost, not necessarily, no. Let's do a process of elimination. So letter D, out. Mild tooth discoloration, of course, out. No, so we're now left with B and C. Okay, so letter C, tooth with minimal crown destruction. Minimal, very little. Okay, versus peg-shaped lateral, now where it's narrow all around. Then, yeah, the answer here would be letter B. Okay, number 53. An endodontically treated tooth can serve as an abutment for bridges and partial dentures, provided it has completed occlusal coverage to prevent fracture under load, and cuspal protection reduces the risk of vertical fracture. Mm. An endodontically treated tooth can serve as an abutment for bridges and partial dentures, provided it has completed occlusal coverage to prevent fracture under load, and cuspal protection reduces the risk of vertical fracture. Okay? O ano, ito na naman, isa na naman tong pinagtatalunan sa clinic. Answer, A or B? Dun, 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 dun. Diba? More. I only have two answers so far. Okay? O yan ah. You all understand, no, that, yeah, it can, no? So, true. Okay? You can use this as an abutment, no, for bridge or for RPD. Of course, it's still a matter of case selection. Okay? No? Uh, and also the amount, you study the amount of load that you're applying on this tooth. And mamaya, you made it an abutment, no, for a cantilever with a long span. Di syempre mali na 'yon, di ba? No? But if it's an abutment for a bridge, no, and the patient's bite is okay, no, why not? No? No. The errors here actually the errors that you could possibly encounter here are not because of the uh, tooth being endodontically treated, no, but the usual errors that I will see is actually because the patient's bite was not studied well, no, or the margins are very far from where they're supposed to be, no. So no, it's not because of the no, it's not because it's endodontically treated. Okay? Ayan. So, ayan na, ayan, naging mainit tuloy yung pag-discuss ko. Kaya lang kasi it's related to all of the misconceptions that I've been encountering in the dental wellness center and even outside. Okay, so medyo may kasamang gigil yun. Anyway, number 54. Let's discuss until 55 and then we'll take our lunch break. Okay? Number 54. Extensively damaged teeth with significant loss of tooth structure can be reinforced using a cast coronal restoration or dental core, which requires retention and stability from the root canal and pulp chamber. Okay. Now, so there would be instances wherein now there's a significant loss of tooth structure, and then you will need to do a custom, no, uh, core, no, or there's also what you call an endo crown, no, pwede rin yun. May kasama siyang sa chamber na component or sa canal na component, parang single piece na sila, no. Um, yeah, so you can get no retention and stability from inside the canal and pulp chamber. So this includes also your post and core. Okay, so yeah, the answer here is true. Okay, now what you need to prioritize no is yung ferrule. Okay, there should be ferrule, and of course your margins should respect no the biologic width, no. Okay, or supracrestal anyway. So yun. Um and it's another thing that I encountered ito sa ESP to, no, nung March 28 din nga. So annoying. The last speaker no as a proponent of biomimetic dentistry, no, no. Last speaker kasi siya kaya hindi na ako nagkulit or nagtanong or and I'm feeling na lahat ng tao ganun rin. Uwing-uwi na lahat ng tao eh. Because it was a Sunday. And then she was the last speaker. And another reason is because she just told everybody that she just recently recovered from cancer. So who wants to be the bad guy, no? And uh disprove the things that this person has been saying. Pero this speaker was highly sobrang kabaliktaran naman. She was highly dependent on adhesive dentistry, no? And even disregarded no and said that you don't need the post, you don't need ferrule, you just use adhesives. And we're like, what? This as in I am please no no please don't get me wrong, as a former teacher of oral anatomy for a very, very long time, I truly respect the design of nature, no, in terms of the tooth, in terms of the contours, the contacts, the casts, the grooves, and whatnot. And that's why I respect biomimetic dentistry for that reason. Okay? But if you're telling me that you're just gonna use dental adhesives, no, to replace the entire crown that's lost, no, that's gonna be, you know, as in, as in, yung composite nakapatong doon, just using adhesive. Walang, wala nang halos yung crown. No? And I'm like, huh? And she was saying, "Oh, this is evidence based. This is evidence based." And I'm like, "Where is your evidence? Show us the evidence. Don't just say it's evidence based." She herself, at the beginning of her lecture, told us that people have been calling biomimetic dentistry as a cult. As a cult, she was well aware of it. So, if people have been saying that your field is a cult, and now you're telling us that this is evidence based. Then show us the evidence. Don't just show us cases that you finished recently. We need studies, long-term studies that prove that what you're claiming is correct. No, no, and we need a good enough number to believe. No, in terms of time, in terms of number of cases. No, and these have to be well documented. Okay, so don't just claim, oh, it's no, it's evidence based, where? Okay, now because what she was saying was actually violating so many principles, of restorative and prosthetic dentistry. So I was like, okay, it's just nobody wanted to ask anymore because everybody wanted to go home, and nobody wants to be the bad guy for somebody who just recovered from cancer. But really, no, that was that was also something that really riled me so much. Anyway, now don't just believe everything that you hear, ha? At hindi porke sinabing evidence-based, tango lang kayo ng tango. Ah, evidence-based. Tanungin nyo, where's the evidence? Show it. No, you only you know what's written in your textbooks. You sometimes you will see in your textbooks contradicting ideas. That's because they gathered information from multiple researches. Now usually these are from what, literature reviews, um at the very least, at most, or well, systematic reviews, and the highest would be the meta-analysis, which have undergone so much screening, even testing for bias. No, there are tools, no, for screening these studies before they come up, no, with this information that they're presenting. Now, the same goes for the information that's being brought out and released and accepted, by our reliable organizations such as such as AAE nga. So if AAE produces a statement, an official statement, then that's because it came from so many pieces of long-term evidence. Okay, it might be changed in the future, yes, but no, for now that's the best. No, that's the best evidence. No, has produced this statement. No, so if you have a speaker, because sometimes they will invite speakers without screening what they're gonna say. Okay, so sometimes you'll just be shocked by what the speaker said. Okay, just like in that case. No, they're like, no. Even Malamed, no. So Malamed is is a well-respected author. He's gonna be coming again in PDA convention. He's like a rock star when he comes over in the Philippines, no? But you don't necessarily have to agree with what everything that Malamed is saying. Okay? No, kahit Malamed pa yan. Okay? You use your common sense also. Okay? All right. Yan. Magpakwento kayo kay Dr. Javier tungkol kay Malamed. Anyway, may kwento siya. Number 55. So this is our last question before our lunch break. No? Number 55. A one-piece casted post and core weakened tooth restoration and is never indicated for undermined teeth with mesial or distal fillings. A one-piece casted post and core weakened tooth retention. Okay. So while a post, no, will not make a tooth stronger. Okay, but definitely, no, the purpose of a post is for retention. Okay, okay, no. So, no, this statement is false. Okay, okay, all right. So we will have our lunch break. Okay, and I hope that you'll uh, give me your attention pa rin, no? And uh, here. Hindi kayo natakot na parang nagalit yata ako. No, it's just that there are really some lecturers and there are some na kung ano-ano pinagsasabi na hindi naman matino yung basis. That's why I'm, you know, parang parang false advertising, gano'n. Or minsan, sometimes they just want to say something that's out of the box para lang they appear cool, you know, no? Or they appear unconventional. Yan. Katulad ng concept ng ninja endodontics. Ay nako, isa pa yan na galit ang mga endo dyan sa ninja endodontics na yan. No? Please, ha? No? Wag wag nyo. Wag nyo mabanggit-banggit yan sa ano, ng endodontics. Baka sakalin kayo. Anyway, so, oo, gigil na gigil na dyan. Pa-cool kasi, di ba? Cool kasi sa pakinggan ninja endodontics. Anyway, so we'll have our lunch break and we will resume siguro ano na lang 1:30. Okay? No, so let's not rush.